On the risk profile, the cost effectiveness varies a lot, and you cannot put all of this on one big pile. You have to individualize therapy. So based on clinical common sense and cost effectiveness issues, there is number 4, prioritize subsets with high propensity for restenosis when using drug-eluting stent versus bare metal stents. Now, can we easily identify those patients? Yeah, relatively well. They did it in the basket trial, shown here. The small vessels or the bypass graft intervention were considered high risk. The large vessels, more than 3 millimeters, were considered low risk. And here is the outcome. If you look at MACE, the risk, all adverse events, or the need for repeat intervention at the bottom, if you have low risk, it doesn't matter whether you use drug-eluting stent or bare metal. It's the right part of the graph, while you have very significant difference if you have high risk in favor of using drug-eluting stent. So vessel size and vein graft intervention. Another way to represent this is to combine, again, the vessel size and the stent length. This is a 3-dimensional graph that tells you about the estimated risk of restenosis in native vessels if you were to use a bare metal stent according to 2 simple parameters: vessel size on the horizontal axis and lesion length at the right part of the slide. And you do see that the propensity for restenosis is quite variable. It goes from 2-3%, very low, up to nearly 60% in the very long lesions in small vessels. So based on this chart, it is relatively easy to identify what the risk of restenosis might be if you were to use bare metal and use DS when the risk is high. In doing so, you will reduce reintervention and be cost effective. There is also lesion characteristics. Besides lesion characteristics, there is patient subsets that benefit from drug-eluting stents, and number 1 to remember is diabetes. So very easy. Lesion length, vessel diameter, diabetes. This is from the large network meta-analysis comparing the outcome in terms of need for reintervention in patients with diabetes on the left versus non-diabetics on the right. The curve in blue on both graphs shows the restenosis rate and the need for reintervention with bare metal. 2 messages. In diabetic patients with bare metal stents, the restenosis rate at 4 years is as high as 25%, 1 out of 4. And this is reduced significantly to around 15% at 4 years. It is reduced to less than 10% if you use drug-eluting stents. So what you do see here is that the risk at baseline is much higher with diabetics, and that you can reduce it to the same extent with drug-eluting stents. Again, a very cost-effective choice of therapy. Now this is for groups. Does it really work when you have an individual patient in front of you? Well, with individual patient, you also have to account not just for the efficacy of drug-eluting stents, but also for the risk. And the risk is what? It is stent thrombosis. Stent thrombosis has 2 distinct components. The one that has been talked about a lot is this late stent thrombosis. What about the threshold of risk for late or very late stent thrombosis that is acceptable or unacceptable? A somewhat complicated slide, but very important paper. Horizontal axis is again the rate of failure if you were to use bare metal. So it shows bare metal target vessel revascularization rate from very low, 5%, to very high, 35%. And the vertical axis is the incremental risk of having a late stent thrombosis every year if you use drug-eluting stent, first-generation drug-eluting stent. And the line in between the two there is the line of equipoise. It means that if you fall on that line, it doesn't matter. Anything above favors bare metal, anything below favors drug-eluting stent. So it's very simple. Let's take one example. Very low risk for restenosis, large vessel, short lesion. If I were to use a bare metal, the restenosis risk would be 5%. Then, if I would go for drug-eluting stent, I can only accept a very, very low risk of very late stent thrombosis. While in the opposite situation, where the risk of restenosis is very high, there the equipoise line goes up, and I can tolerate a higher risk of late stent thrombosis because the benefit is larger. Now, the late stent thrombosis issue is not solved, but it's understood. We see it primarily so far with paclitaxel and sirolimus. We don't know yet whether it will be eradicated with the newer generation stents. What Dr. Windecker has shown is the mechanism. It is hypersensitivity. It is delayed hypersensitivity to one of the components of the stent polymer drug combination. This hypersensitivity causes a necrotizing arteritis, necrosis of the wall, such that the late malapposition occurs. It's a very rare phenomenon, and it is these pockets that are responsible for the late stent thrombosis. Now, the late has received much attention. It is not fair, because what would receive a lot of attention is the early one, and on this slide showing each of the events here, you see that there is many more early than late. So even if the newer generation stents can eradicate late stent thrombosis, early will still be around, and that is a complex thing where we have many factors that play a role. Many of the lesion and patient factors are the ones that are also associated with high risk of restenosis. So high risk of restenosis and high risk of early stent thrombosis go together. Issues with dual antiplatelet therapy. I'll go very briefly. In fact, there is a number of clinical situations where you worry about having to give dual antiplatelet therapy to the patient. In those cases, you should think it over twice before giving the drug-eluting stent, and you should consider bare metal. Let's very quickly go through the list because it's clinically and practically important. Patients who absolutely require Coumadin, AFib, prosthetic valves. Patients who have had repeated bleeds, be it GI or cerebral. Patients who don't respond to thionopyridines. Patients who are scheduled to undergo elective surgery. Patients who are not compliant. Patients who cannot afford the drug. Patients with comorbidities, particularly elderlies, because they are likely to need diagnostic or therapeutic procedures, and perhaps patients with advanced age and polypharmacy. In all these patients, you should worry about the consequences of implanting a DES, that is to say, long-term dual antiplatelet therapy. There is a couple controversial off-label indications that one should worry about. 4, SVG, vein graft intervention, still controversial. So you may do it, but think it over twice. Complex bifurcation with last sides branch, particularly crush, complicated techniques. Primary PCI for STEMI still is debated, although there is some good data. And finally, as was already alluded to briefly by Milan, multivessel PCI with very complex lesions where you need to put several stents. You should refrain from doing drug-eluting stents and consider surgery. So the very high syntax score, the syntax score that captures the complexity of the anatomy, if it's very high, you should perhaps beware of the fact that this indication might be controversial. In the interest of time, I'll shift to the last few items here that should be considered. I think it's important to use validated devices. This is from the Swedish SCAR registry. It's tens of thousands of patients And each of these curves is the rate of restenosis over 3 years' time for a given stent brand. Now, it doesn't matter to look now which brand we're talking about, but what's obvious is that there is 3 clusters here. The lowest restenosis rate is with drug-eluting stent, of course, but even for bare metal stents, there is huge differences in their propensity for restenosis, adjusting for lesion stent diameter and length. So not all devices are equal. Not all DES are equal. Not all bare metal stents are equal. This slide shows it for efficacy. It is also true, most likely, for safety. So these are, according to the guidelines, the validated drug-eluting stents that are available, at least in Europe, with CE mark. And there is even a difference between the two. The first group have the strongest data because the pivotal trials were designed and powered to address clinical endpoints, and they're listed here: Biomatrix, Cypher, Endeavor, Taxis, Science V, Promise. There is also good evidence, somewhat less robust because it's based only on angiography, for Nobori and Yukon. I say one word about Endeavor Resolute. We don't have the pivotal yet. It will likely be released later this year when the results of Resolute 3 will be published. Proper implantation technique. I'll skip it. It is extremely, extremely important. It's not because you're using a stent that has low propensity for restenosis that you should not implant it properly. And the main point here is to make sure it is fully deployed and that one reaches the largest possible diameter of the vessel. That is adequate stent expansion. Residual dissection should be avoided, and excessive stent hardware, as I've mentioned, is not the way to go. We should restrict the number of stents as much as possible. And the final comment is have a frugal attitude. More is not better. It's not because you put more metal in there that the patient will do better, as was actually shown based on the famous study, the fractional flow reserve measurement. What this measurement does is that you decide to implant a stent only if you see this pressure drop here when the pressure sensor crosses the lesion. So if the lesion is significant, you're allowed to stent. If the lesion is not significant, it may look better with stents, but it will not do any better to the patient. And this was demonstrated in the trial. Just one short point. The outcome was better in physiology, ischemia-driven intervention, than with anatomy-driven intervention at 1 year, at 2 years, and it was consistent for all the components of the endpoint. The key point here is that these better results were obtained with fewer stents, because in the FFR group, patients received on average 1.9 device instead of 2.7. So more is not better. Thank you very much for your attention.